All right. So where are you from, Meghna?
I think Praneeth, if you've asked Praneeth where he's from, I'm from the same place.
Oh, gotcha. Are you
Yeah.
guys all from Austin?
Mm-hmm.
Yeah, we're all from
Oh,
Austin. Yeah, we go to the
awesome.
same high school too.
Yeah,
Which
same
high school
school.
do you guys go to?
Vista
Ridge High
Ridge.
School.
Okay.
Yeah.
I'm originally from San Antonio, so that's why I ask.
Okay.
So I know a good amount of Austin. I live in McAllen currently, but I'm very familiar with the area. Traffic is brutal there. That's all I can say.
Yeah, it's only getting worse.
Yeah.
Yeah.
Yeah. Amon should be coming and then we can like get started.
Awesome. Fabulous.
Yeah, I think he's having some like computer issues, so
Oh, no
sorry.
worries.
Yeah.
We can take his time.
I like how my school email was like, we cannot confirm that this email came from Praneeth Saja. It looks like it did, but we can't confirm it. Be careful opening any links in this email. And I was like, okay, sure.
Yeah. I'm not to be trusted.
Yeah, it's just you.
So you guys all what grade are you guys all in? The seniors, juniors, sophomores, freshmen?
We're juniors.
Junior.
Awesome. Fabulous.
Yeah, we're doing Cure for Care as part of a DECA project actually.
Okay.
So our event is Project Management Career Development. So the purpose of our event is to design and manage a project which promotes a career related to management, administration, finance, things like that. So we saw the flaws were exposed in the healthcare system during the COVID-19 pandemic. And so that's why we thought it would be a great idea to promote healthcare administration since it's such an important field. And even if someone isn't like wanting to become a healthcare administrator themselves, we felt that it was important that they at least were aware of what was going on. So.
Yeah, absolutely. I can speak on personal experience. Being a physician, there's been so many more admin jobs. If you look at the last 2 decades of admin jobs to physician growth, the unfortunate aspect I think we've seen in healthcare, especially since the 1996 HIPAA Act, is healthcare administrator, the curve just goes very exponentially compared to physician growth. And a lot of it is just due to the amount of regulatory burden that physicians are facing, whether it's prior authorizations, whether it's just general paperwork that needs to be filled, credentialing for physicians. That's been really an issue that's going forward. But the big hurdle that I'm seeing with administration is just the lack of right experience. May I put it that way? You're seeing a lot of these people that are really people that with MBAs, but they really come from private equity or corporations, and they really view medicine and run a hospital from a business standpoint, rather than a standpoint of what is the best thing for my patients. What can I do to bring more equity to my patients? What can I do to provide the proper needs for these patients that are there? And I think when you run healthcare as a business, our patients suffer at the end of the day. And so I think your mission is challenging on that realm. You have to find a way to empower the right people to get into healthcare administration, is what I feel. People that view equity, people that know that there's systemic racism in medicine, people that know that they're disadvantaged people and people that have privilege, and they should be treated on the same page, on the same level. So I think those are kind of the challenges. But I love everything that you guys are trying to do.
Yeah, we were actually like talking to a very similar organization to Doctors in Politics. We were talking to future Doctors in Politics on like.
Absolutely. So they're our C4 arm. So that's Inam is the founder and president of it. I don't know if you met her.
Yeah, we're going to talk to her on Friday again. So.
Yeah, great. She's amazing. And they're our C4 arm, and we're their political action committee. And they're trying to get more medical students become more politically engaged, to realize that, in order to really change healthcare, it really stems from policy. And the people that make that policy are really politicians. And in healthcare right now, you just don't have that representation in legislation, in legislature right now. When you look at, I think, the Congress right now, the House and the Senate, I think there's 14 physicians that are there. Only one of them is actually Democratic. And so that's why we really haven't been able to have, proper policy being advocated. We're not here advocating for the Rand Pauls and, the other Ben Carsons. Like, that's not what our group is. Our group is definitely more progressive. And we have 6 pillars that we primarily try to focus on, whether that's, quality healthcare for everyone, education, being from whole child development. We also have, gun policy being a public health crisis, climate change being a health concern. So we have 6 of those pillars, and that's kind of what we want all the people that we endorse that run to. Aman's here. That's what we really want them to embody ultimately. So.
Oh, hi, Mr. Gogu. I'm extremely sorry for joining late.
No worries, Aman. Pleasure to meet you. I realize you guys are all from Austin, so that's fabulous. A little bit about myself. So I'm a physician in the Rio Grande Valley. I do family medicine, sports medicine, and pain medicine. And at the height of the pandemic in April, being a family medicine physician, on the border, especially because I'm on the border with Texas and Mexico, there's just not enough healthcare providers down here. And so I was forced to, be a hospitalist, cover the units and everything like that during the pandemic when it was really high in October, I believe. But that really, the thing that really brought upon frustration, at least in me, when I see patients, when I go into a patient's room, every decision that I make that's in the room, my difficulty in treating a patient, it doesn't stem from the medicine that I've learned in medical school or residency or the training that I've had. It really stems from the policy that is there around my patients. So what I mean by that is when I go see a patient and I step out of that room, if I give a medication, a lot of times that medication gets denied. Because why? There's a pre-authorization that's required. Why is there a pre-authorization required? Well, that's what insurance companies are forcing us to do. And they're allowed to do that. Another issue is when I go type or document in a patient's chart, I have to hit certain documentation metrics, none of which affects the quality of care that I provide to the patient. For example, I have to hit, 8 review systems, or I have to hit 6 physical exam findings that are there. I have to hit certain points on the HPI. All of that documentation, while granted, we should document and say what we're doing, but to have it at such specific levels for the sole reason of reimbursement and hitting reimbursement goals is really not providing good quality patient care with the patient. When you look at telemedicine at the very height of the pandemic when it happened, you could see that in-office visits and telephone visits versus virtual visits, those are all being treated very differently for physicians and really affecting our patients as well. And so there's many different examples that I can give that I struggled with coming straight out of fellowship for that. And I think, and then if you also look at the shortage of PPE that many physicians were dealing with at the height of the pandemic, I wore some of the same PPE for, a couple of weeks, but not only that, at the height of the pandemic in my hospital itself, we could not get basic medication for treating COVID. One of the big medications there to treat COVID was remdesivir, and we did not have it. And so the only way we were treating patients was with oxygen, going to high flow, going to nasal cannula, going to a ventilator, that's a BiPAP, that's how we were treating it because we did not have basic medication. And so a lot of these are just, decisions that are made a lot of it is on a political level, sadly to say, and a lot of this gross mismanagement of this pandemic was political. And so I think that's where I got really frustrated, and there was a group of other physicians that I'm with as well that got frustrated as well. And then we created Doctors in Politics, which was a political action committee. And so what our goal is to do ultimately is to endorse physicians to run for office, whether that is a congressional seat, a Senate seat, a legislature seat, a mayor seat. And that's what we did. And so in this past cycle, you guys might know Pritesh Gandhi, who ran in Austin. He might actually even represent your area. He was one of the candidates we endorsed. He unfortunately didn't win his election, but winning is not everything, which that election proved. He eventually now is a chief medical officer for HHS now. You know, that's an appointed position that, you know, Biden gave to him because he ran a really good campaign and he has experience. I think he works for Austin Regional Clinic, if I'm correct. There was another candidate that we also endorsed. He also didn't win, which was Cameron Webb. However, now he's on the Biden's, I think, COVID equity task force, which shows that, you know, winning was not everything for him either. And there's another candidate as well that we endorsed that won in Georgia. She was the first Asian American female to win in Georgia for state legislature, and that was Michelle Au. And so she's one of the people that we've helped get into an electoral seat. And we've endorsed other candidates. Unfortunately, they haven't won. But winning is not everything, because winning changes the conversation for the other side. And so this cycle, we're now recruiting candidates to run. We've spoken to many candidates that are physicians, and the goal is hopefully to get as many in office so that they could advocate for progressive change that really reflects the needs of our patients. And so that's the goal that we have. So yeah, that's a little bit about us.
Yeah, I mean, all the issues you talked about in this pandemic, they're like even more concerning when you realize that the US spends more on healthcare than like any other nation, and like by a lot.
Correct.
Too. So it's completely due to like the fragmentation of the system and the mismanagement, as you said. So it's really important to raise awareness and like politically advocate for this healthcare reform. So thank you for all the work that Doctors in Politics is doing on that front.
Yeah, no, thank you. And tell me a little bit about you guys and what you guys are trying to achieve and move forward with.
Our project, Mr. Gogu, is Cure for Care, which is a part of our DECA organization. So, just to start off with, we are a part of the DECA team, the DECA chapter, and DECA chapter is where you compete for several business type events. So we specifically chose project management, where you promote careers, any career you choose. We specifically chose to promote healthcare administration because they've been noticing how healthcare administration is not being given as much importance as it deserves. And while exploring that, we have seen several issues regarding it. We have seen how the healthcare system is fragmenting, and especially because during the COVID-19, these issues were highlighted. So moving forward, we also realized that there's also issues in the politics side, because politics has a huge role to play in healthcare administration. So what our team decided to do is collect information regarding this aspect of the project as well. This aspect of the project had a little bit of weakness as we haven't researched much, but now talking to Doctors in Politics, and we also had a meeting with future Doctors in Politics a couple of days ago. We're trying to gain more knowledge about what are the issues that lies between politics and healthcare administration.
Yeah, absolutely. Yeah, that's what I was just talking with Praneeth and Meghna. You know, I love what you guys are doing. I think the big thing with healthcare administration is actually getting the right people into healthcare administration. And I think a lot of times right now what we're seeing is we're getting these CEOs of these hospitals, or COs or CFOs, or people that are just there in admin that really come from the private equity sphere or come from the corporate sector. And their whole basis, and you put this in your PDF as well, is that being the wrong economic model. because what they're trying to do is make as much profit as they can, but at the expense, what's happening is patients are suffering. So I give you a good example of this, for example, like nursing homes, right? We all know about the New York issue with Cuomo and all of that, but forget all of that. The nursing home issue that's there, a lot of those nursing homes there are actually run by private equity groups or corporations. And what they're doing in essence is they're saying, well, I don't want to pay for PPE. Let's save money that way. I want to make the nursing to patient ratio, instead of being 1:2 or 1:4 for this geriatric population, let's make it 1:8. So I don't have to pay for more nurses to cover for these patients. So what happens at that point? Well, patients suffer, right? Their glucose is not getting monitored. Their vitals are not getting monitored. So there's more mistakes that could potentially happen for that patient to have an adverse event that's there. What about storing medications, right? Or storing, IV fluids and so forth. They make cuts like that. And at the end of the day, these patients do suffer. When it comes to food, even just simple food and activities, these patients are not getting that. And so I have a lot of nursing home patients that come to my clinic, and ultimately they're very dissatisfied with the experience they're getting. And they come to me stating, well, this is now a business, this is run by the corporate sector. And so who makes those decisions, right, for that nursing home? Well, it comes from the admin. It comes from the CEO. It comes from the CFO, the COO. But that's where the big problem is the ideals. If their ideals are so to the right in terms of making profit, patients are going to suffer. And so how do we fix that? And I think it's by policy, by state legislatures more likely, is where now you mandate nursing homes to have a 1:2 nurse to patient ratio, or you mandate that this is how many nurses have to be for this many beds in a hospital, or you mandate that, hey, there has to be a physician on site 100% of the time in a nursing home. There's certain things that they have to mandate for. And so those are just some examples, and I think it comes from a policy standpoint. So yeah.
Yeah, I definitely agree. Like, we should be making the transition towards more compassionate care rather than corporate care. We
Correct.
interviewed a local healthcare administrator in our area as well, and then he was talking about how at least their facility puts patients first, because a hospital or like any healthcare facility is different from, it should be treated different from other types of businesses, because you're not just selling a product, you're not supposed to be selling, you're supposed to be taking care of people.
Correct.
So I feel like, if, as you said, if these nursing homes are being run by private equity, we're missing the whole point of what it means to be a healthcare facility.
Absolutely. Absolutely. I totally agree with you. And then the other big issues that we're seeing, in terms of equity, that's there from a racial standpoint. If you look at a lot of these, some of these hospitals and nursing homes, a lot of times the worst run ones are in neighborhoods that are having minorities, that are disadvantaged, and so forth. And there has to be equity from that standpoint as well. You can't just have all the good nursing homes, all the good hospitals in the really good areas of town. And you see it in Austin pretty evidently. You know how East Austin looks compared to West Austin. And so how do you make equity, fair for both sides? Because healthcare should be equal for both sides of the aisle. And unfortunately, it's not. It's very different if you're a minority. It's very different if you're poor. It's very different if you're uninsured. And it shouldn't be that way. And that's, insurance is a whole nother gamut that I didn't even mention. But that a lot of those policies stem from, governmental policies and having good policy for everyone getting insurance. And unfortunately, we've had, this whole, the GOP and, the entire Trump administration trying to undermine the Affordable Care Act, which really hindered a lot of patient care. But I don't think the Affordable Care Act is everything. I think we need to go above and beyond that, because it doesn't cover dental care. It's really not covering mental health, which is a big issue that's there right now. It's tied to employment. And this pandemic really undermined that, because a lot of people lost their jobs and their job was tied to insurance, and they ended up trying to seek care, and now are getting enormous bills. So there's just a lot of issues, and all those are policy issues that are political, as you can see. And that's what we've really realized and picked up on. And unfortunately, a lot of doctors have been apolitical in this process. And so it's time that our goal, and future doctors in politics, their goal is to get medical students involved. We're getting residents involved. We have a talk with the resident union. That's hopefully we can get them involved as well. We're getting attendings involved as well. And then pre-meds, we're working on that, and now I'm talking to you guys, which is exciting, the high school students. So I'm real excited.
I think you've mentioned equity a couple times, and I think that's a very good point that we haven't really touched in our project. Our target audience was just, 3rd through 12th graders, so very broad, but not necessarily like picking on any specific groups. But I think, or do you think that maybe including more diversity in background among healthcare professionals and healthcare administrators might help mitigate some of these inequity effects that we're seeing right now?
I'm so glad you brought that up, and I totally agree with you. That's one thing that I think we've been really advocating for. Is I think if you look at most of the there's actually something I've been talking about with my group. Is 90? I think if you look at the studies, 90% of healthcare administration is run by Caucasian people, and I think it's Caucasian males, if I'm correct. If I remember the study correctly, and so that means 10% are really minorities. And so, for example, I look at my hospital system where I work at. I'm in a deeply Hispanic area. 90% of the area is Hispanic, but the entire administration is run by people that are not Hispanic. They're run by Caucasian white males, and I think there's a big difference when you have someone that represents the area that you're in running a system, because they understand the people. They understand, what their struggles are. They can relate to those people. They can bring about fairness for those people. They can bring about equity for those people. And I don't think you're having that, unfortunately. The other big thing, if you've also looked at training programs, residency training programs, which train doctors, a lot of those attendings that are program directors or assistant program directors, they don't represent the communities that they're part of. Because if you look at a lot of these training programs, are often in underserved, low income neighborhoods. And I think you should have them reflect the people that are of that area, because they could, I think, provide the best care for that group. So absolutely, I think that's something that is very, very, very important.
Yeah, definitely. I mean, we talked about this with FDIP the other day, but the person we talked to, Emily, she talked about how in medical school even there's a lot of information about the science behind treating patients, but there's really not much about healthcare policy and things like equity. And I think as we move forward, we should definitely include that as part of the education of future doctors, because it's just as important as an issue as just treating scientifically is.
Yeah, absolutely. I totally agree with you.
And these go unnoticed, because most of the times when we see a failure in administration, we usually blame the administration or the doctors, but we forget about the policies that really make them. So it's hard to notice them as well.
Yeah, it is, and I think there's just so many. The issue with healthcare is you just got so many people have different priorities, and I think right now it's just really stemmed to becoming profit, and ultimately, minorities and low income people are really suffering at the end of the day. But if you get people that represent the people that they serve, I think you might be able to convince maybe a CEO or someone in admin to say, hey, maybe I'll push back on that corporate, because ultimately a CEO has to report to the corporation's CEO and their board. And so maybe you'll get some advocacy saying, hey, our patients here are suffering. Can we do X, Y, and Z instead of this A, B, and C? And so you'll get a level of engagement there. And so I think equity is a big thing that I would definitely focus on if I were you guys in terms of healthcare administration. If I have the article that I was reading that showed 90% were actually Caucasian males, I think you'd really see it. And I think another thing is you don't see in administration is you don't see many female administrators that are out there, and I think we need to see more of that as well, because a lot of the healthcare issues that are there, some of the women's health issues that are there, really would be better advocated for from a female administrator than a male administrator. And so I think equity just plays such a big role, and I don't think we see it in healthcare.
So a lot of your talking points have kind of been over like representation and making sure that if you are serving a community, that the leaders of that community reflect said community. So kind of with that in mind, would you say, do you think the most impactful changes to healthcare policy and sort of the culture surrounding healthcare, do you think those would come from like smaller groups like, state legislature or even local cities, or would you say that would come more from the federal government and like presidential?
Yeah, that's a great question. So yeah, it's a loaded question too. So I think when you look at something like health insurance, I think that would come from federal, from the federal government. But I think if you look at states, for example, women's health issues, particularly when it comes to Roe versus Wade and abortion and so forth, that's really coming from state legislatures that are making those decisions ultimately. When it comes to transgender health, which is now becoming a big issue, that's coming from state governments that are making those issues, those mandates, such as South Dakota, I believe, and I think Mississippi or Arkansas. One of those states really didn't want to fund transgender health, if I was correct. I can't remember which state. So it's very different when it comes to scope of practice. How much whether nurse practitioners or PAs could practice independently. That comes from the state legislatures. So through my experience, I feel like a lot of the decisions that are made for a state really comes from state legislatures that I've learned. And a lot of times we don't pay attention to those races because we pay attention to the Congress, the Senate, the president, but we don't pay attention to the state legislature, the House and the Senate. And those races make big decisions.
So like one more thing, you talked a lot about like insurance and how that shapes healthcare administration. Could you like elaborate a little bit more about why insurance is playing such a big role in our healthcare administration and how we take care of patients?
Yeah, so right now we have insurance tied to employment, especially during this pandemic, and unfortunately this pandemic really there was a K-shaped recovery where people that could work virtually or people that could have an occupation otherwise were doing well, but people that could not sustain, whether you're in the restaurant industry or the service industry that had insurance tied to that industry, they lost their jobs and ultimately they lost their insurance. And their choice was to get onto a plan called Cobra, which was to pay for it out of their pocket, which ultimately they didn't. And so right now we have that issue where insurance is tied to an occupation, which I think needs to change ultimately. And I think you gather from what I'm saying is that I'm more of a proponent of a single payer system, is what I'm really for, because I think that's what will really solve a lot of these issues. But that's one issue. And I think the other issue as well that we have is we have a huge Medicaid population, particularly in Texas, that's there right now. And we don't have enough Medicaid funding. And what does Medicaid really fund? Well, Medicaid really funds the underserved, the low income households that are there in Texas. And so we need more funding that way to go towards that way. And so ultimately, I would like to see more Medicaid funding, but that comes from state legislatures and propositions that are voted upon by voters in the state for Medicaid expansion. Other issues that you see as well, particularly, is is Medicare as well. Is with Medicare, you have it until age 65. And then below that, you have to have a private insurance. But what if we allowed, patients to buy into Medicare? Well, that would allow more competition with this private insurance industry, where it could potentially lower it. But unfortunately, when Obama was president, they were lobbying heavily against the public option, because private insurance knew that they wanted to get competition away, and so that's why the public option didn't pass. And so and hence another reason why I think you need the right decision makers politically to advocate for the right things there. And I think the other thing that I didn't mention, and I think we need to have a solution to this, is the undocumented population we have here. I think we should be able to somehow be able to take care of them in a morally and ethically way in the United States. Because a lot of times I see patients in the hospital here, and they come in and they're towards the latter end in terms of their health. And I think that is costing the system tremendous amount of dollars, when if you could prevent them from coming to the hospital, you could save a lot of money for the hospital systems, and ultimately save a lot of federal dollars. So I think, we need to find a way to take care of them as well. And lastly, and I think you're seeing this a lot with children. A lot of children come under CHIP and Medicaid and so forth. And a lot of these children's hospitals, and we're seeing this all across the United States, wings are being shut down because CHIP and Medicaid does not pay the same as commercial insurance. And so what these hospital systems are doing, which is regulated once again by healthcare admin and the corporate aspect, is they want to make as much profit. And so they shut down wings completely to make as much profit as they can. And so those are some of the issues that I'm seeing with the insurance game.
Thank you so much for actually providing us these insights, because most of the times you'll be just aware of these issues, but not aware of its actual cause and what's causing what's basically behind those scenes.